Hi, good afternoon, everyone, and a warm welcome to all the participants of today's webinar. I'm Dr. Tan Chin, and I'm the Secretary of the Section of Clinical Immunologists and Allergists. With me today is Dr. Grace Chan, Vice President of the Allergy and Clinical Immunology Society of Singapore. Today's talk is on food allergy from infancy to adulthood, and we are pleased to have 4 distinguished speakers from pediatric and adult allergy to give us their expert insights on this very broad topic. Before we begin, here are some housekeeping rules. Firstly, we request that all participants have their names and MCR numbers displayed on your account for purposes of CME registration and verification. We would like to remind all participants to kindly be on mute throughout the talk. We'll be leaving the Q&A session to the end of the webinar, but in the meantime, please feel free to type in any questions in the Q&A panel, and these will be answered either at the Q&A session at the end, or responses will be typed into the chat itself, as we do anticipate quite a number of questions for today's webinar. Without further ado, I hope you enjoyed today's webinar, and I'll pass the time to Dr. Chan to introduce our next speakers. Dr. Chan, please.
Thank you. Thank you for spending the Saturday afternoon with us. I would like to introduce the first speaker, Dr. Samantha Lee. Dr. Samantha Lee graduated from the University of Melbourne and has been in the allergy service in pediatric medicine, KK, and Women's Hospital since 2011. So she has been experience in pediatric allergy for a long time, and now she is a consultant in the pediatric allergy in KK Hospital, and we are happy to welcome Dr. Lee and to invite her to share on the topic food allergy manifestations and diagnosis in children. Dr. Lee.
Okay, can you guys hear me?
Yes, we can hear you.
Okay, and you can see my slides, right? I will start then. Yeah, thank you so much, Grace, for the kind introduction. A very good afternoon to everyone. I'm Samantha, a pediatric allergist in KK Hospital. Thank you for spending your precious Saturday afternoon with us at this webinar today. We are coming to the end of year 2022, and this is a good refresher and rundown on food allergy in both children and adults. I will start my talk discussing on manifestations of food allergy in children, followed by a more in-depth discussion on the diagnosis of this condition. In this talk, I will cover the definition of food allergy and to briefly discuss on epidemiology and the common food allergens, followed by discussion on clinical manifestations and diagnosis of food allergy in children. Now, what is food allergy? Food allergy is an immune-mediated adverse reaction to food categorized into IgE-mediated, mixed, and non-IgE-mediated. In today's talk, I will be focusing more on IgE-mediated food allergy. Non-IgE-mediated food allergy includes food protein-induced allergic protocolitis, food protein-induced enterocolitis syndrome, food protein-induced enteropathy, and the mixed form include the rare entity of eosinophilic esophagitis and eosinophilic GID, and sometimes eczema. It is important to note that lactose intolerance, malabsorption syndromes, and food poisoning, such as scombroid poisoning, are not food allergy. Scombroid poisoning is a form of food poisoning due to consumption of fish that are improperly handled or inappropriately stored, resulting in overgrowth of bacteria that converts free histamine into histamine, resulting in symptoms that mimic an allergic reaction. Pharmacological reactions caused by caffeine from coffee, tyramine from cheese, histamine from tomatoes are not food allergy either. The prevalence of food allergy has increased globally over the past few decades. Based on Gastro cohort study from 2009 to 2010, the overall food prevalence in Singapore is 2.9% at the age of 12 months old. It is much lower compared to Western countries such as Australia, US, and UK. Even though prevalence of food allergy is low locally, anecdotally, we observed an increase in prevalence over the past decade. In a retrospective study done at KKH Emergency Department between 2007 to 2014, the incidence of anaphylaxis was 38 per 100,000 emergency visits, with an average increase of 7.6 patients per year. In Singapore, egg is the commonest food allergy in children, affecting 1.8% of infants at the age of 12 months, followed by cow's milk. Peanut allergy is rare in Singapore population, affecting only 0.1 to 0.3%. Shellfish allergy typically emerges later in life and is in fact the leading cause of food allergies in adults in Asia. The Gastro cohort showed that by 3 years of age, shellfish allergy became the leading cause of food allergy. Various hypotheses have been put forward to explain the increase in food allergy prevalence. This include hygiene hypothesis, vitamin D deficiency, and dual allergen exposure hypothesis. Diminished microbial diversity and vitamin D deficiency are thought to interrupt the regulatory mechanism of oral tolerance and contributing to decreased epidermal barrier function. Dual allergen exposure hypothesis suggests that allergic sensitization to food occurs through low-dose cutaneous sensitization, while early consumption of food protein induces oral tolerance. These are the common food allergens that account for the vast majority of food allergic reactions in children. They are egg, cow's milk, soy, wheat, fish, shellfish, peanut, tree nuts, and sesame. It is also important to remember that in food allergy, it is the protein component rather than the carbohydrate or fat component of this food that leads to sensitization and allergy, except for the rare alpha-gal allergy and galacto-oligosaccharide allergy that arise from the carbohydrate component. These are some of the food triggers unique to Singapore as reported in several local publications, though they are uncommon. These include galacto-oligosaccharides, known as GOS, bird's nest, royal jelly, buckwheat, and Chinese herbs. How does food allergy manifest? I will start off with IgE-mediated food allergy, then followed by mixed or non-IgE-mediated food allergy at the later part of the talk. IgE-mediated food allergy are usually rapid in onset, within minutes up to 2 hours from the time of exposure. They can present with mucocutaneous symptoms such as urticaria, angioedema, erythema, or pruritus, respiratory symptoms such as cough, sneezing, rhinorrhea, voice hoarseness, throat tightness, dry jaw, dyspnea, or wheezing, gastrointestinal symptoms such as mouth, throat itch, or tingling sensation, nausea, vomiting, abdominal pain, or diarrhea, cardiovascular symptoms such as tachycardia, hypotension, or syncope. The most severe presentation is anaphylaxis. Anaphylaxis is defined as severe, potentially life-threatening systemic hypersensitivity reaction. This is characterized by rapid onset with life-threatening airway, breathing, or circulatory problems, and is usually, though not always, associated with skin and mucosal changes. Based on the latest WAO guideline that was published in 2020, anaphylaxis is highly likely when any one of the following 2 criteria is fulfilled. Criteria 1 is when there is acute onset of an illness involving the skin or both the mucous membranes, and at least one of the following, which includes that of airway breathing, such as dyspnea, bronchospasm, stridor, or hypoxia. Number 2, circulation, such as hypotension or syncope or collapse. And number 3, severe GIT symptoms such as severe abdominal pain or repetitive vomiting, especially after exposure to non-food allergens. For food-induced allergic reaction, GI symptoms are common and does not always indicate anaphylaxis. It is caused by the presence of local allergen in the gut rather than a systemic reaction. This in contrast to drug or venom-induced reaction where the presence of GI symptoms would constitute anaphylaxis since the gut is remote from the site of allergen exposure. Criteria 2 is when there is acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient, even in the absence of typical skin involvement. These are not uncommon in fatal anaphylaxis triggered by exposure to food and are increasingly seen with OIT. Skin signs are absent in about 10 to 20% of anaphylactic reactions, and this may result in delay in the recognition of anaphylaxis. There are other unique entities of anaphylaxis that I would like to touch on briefly today. Oral mite anaphylaxis occurs when atopic dust mite sensitized patients consume food that was made with mite-contaminated wheat flour that are left in room temperature. It is frequently triggered by consumption of pancakes, hence the designated term of pancake syndrome. Other incriminated food include pizza, okonomiyaki, cakes, scones, and pasta. OMA commonly affects tropical, subtropical regions like Singapore. Our warm and humid climate serves as favorable environment for house dust mite reproduction. There are various species of dust mite and storage mite that have been found present in the flour in patients with OMA. The next one is food-dependent exercise-induced anaphylaxis. FDAIA occurs exclusively in a patient with consumption of a specific food allergen 4 to 6 hours before or 2 hours after exercise or physical exertion. Both the food allergen and exercise are independently tolerated. Common allergens associated with FDAIA are wheat, omega-5 gliadin, and shellfish, but it can occur with any type of food allergen. It typically affects adolescents and young adults. A provocation test by administering the suspected food allergen followed by exercise is the only reliable method in diagnosing this condition, but it comes with a high risk of anaphylaxis. In FDAIA, skin prick or IgE may not be helpful, except in the case of wheat-dependent EIA, where IgE to omega-5 gliadin may be useful. Oral allergy syndrome, also known as pollen food syndrome, is a mild localized IgE-mediated reaction confined to the lips and oropharynx, typically triggered after consumption of raw fruits and vegetables in pollen allergic patients. Since it is related to pollen allergy, it is uncommon in tropical regions such as Singapore. Symptoms include oropharyngeal itching with or without facial edema and or tingling of the lips, tongue, palate, and throat. It is caused by cross-reactivity of the IgE to pollen protein to the pollen with proteins in fresh fruits or vegetables. However, these patients are usually able to tolerate these fruits or vegetables that are cooked or sometimes peeled or canned. It rarely progresses into anaphylaxis. The previous entities that I mentioned earlier are immediate onset IgE-mediated allergy or anaphylaxis. The next two entities that I will be sharing are late onset IgE-mediated allergy or anaphylaxis that are pretty rare. Alpha-gal allergy is a form of delayed IgE-mediated allergy reaction to carbohydrate epitopes called galactose alpha-1,3 galactose, in short known as alpha-gal, that typically occurs about 2 to 6 hours, even up to 24 hours after consumption of meat such as beef, pork, lamb, venison, or other animal-based products such as milk, cheese, gelatin containing food products. It is rare in our region and are commonly reported in the US, Europe, Australia, and some parts of Asia such as Korea and Japan. In US, the Lone Star tick is the primary cause of this disease, but different ticks are responsible in other countries. Currently, the underlying immune mechanisms linking tick bites with alpha-gal specific Ig sensitization are still poorly understood. The second one is natto bean allergy. It is also a form of late onset IgE-mediated allergy. Natto bean is a traditional Japanese food made from fermented soybean. It has been gaining popularity and increasingly being consumed in other parts of the world over recent years due to its reported health benefits. First case of natto bean allergy was reported in 2006 in Japan. The reaction are usually delayed 5 to 14 hours after consumption and is attributed to the polypeptide polygamma glutamic acid that is present within the sticky mucilage that coats natto beans. These patients are usually tolerant to soybean and other fermented soy products such as miso or soy sauce. Currently, natto bean allergy has only been reported in adults, but we may encounter this in the future since it is known as a new superfood and may potentially be introduced to children for its probiotic benefits. Diagnoses of IgE-mediated food allergy are usually more straightforward compared to mixed or non-IgE-mediated food allergy. Generally, the diagnosis of IgE-mediated food allergy is not based on a single test, and a stepwise approach is usually applied. A detailed clinical history is fundamental in the diagnosis of food allergy. In order to hone an accurate diagnosis, the history must be reviewed within the context of epidemiology and clinical manifestation, followed by careful selection of tests such as skin prick, specific IgE, or oral food challenge. Food allergy is often overdiagnosed due to high perception of food allergy by patients and caregivers. Thus, it is of utmost importance that we as clinicians are able to discern the diagnosis to avoid unnecessary food elimination that may have significant impact on the growth and quality of life. Of course, it is equally important to not underdiagnose food allergy as it carries the risk of severe life-threatening anaphylaxis if missed. Now, I would like to start a poll with the following two cases. This is case 1. 1-year-old boy with background of mild eczema presented with generalized urticaria 30 minutes after ingestion of quarter piece of mashed hard-boiled egg. This is his first exposure, and the urticaria lasted about 2 hours after given cetirizine. There is no intercurrent fever or ARI symptoms. Deborah, do you mind if you launch the poll for me, please? So does this child have food allergy? A, yes, likely. B, no, unlikely. C, not sure. Can we start? Can we end the poll, Deborah? Okay, so most people think that is yes likely, some things is unlikely, and some things is not sure. Okay, let's move on. I'm going to next case, which is case 2. Okay, 1-year-old boy, background of mild eczema, presented with generalized urticaria 30 minutes after ingestion of quarter piece of mashed hard-boiled egg. He has been routinely tolerating all forms of eggs in good amounts. He's been having intercurrent viral infection. The rash eventually lasted for about 1 week. Does this child have food allergy? Can we start the poll? And can we end the poll, please? Okay, so most people think that is unlikely. Some things is still likely and some things that not sure. Okay, all right. Okay, so I wanted to show you this very nice pictogram that illustrates the essential components in the clinical history that will help you to determine if this is food allergy. Firstly, the age of the child. Food allergy is more likely in infancy and early childhood. Time of onset and duration, okay? As food allergy reactions usually occur within minutes up to 2 hours and last for a few hours, typically less than 6 hours. The type of food ingested. Is this a common food allergen? Is this cow's milk, egg, soy, wheat, fish, shellfish, or nuts? The form, such as baked, partially cooked versus fully cooked. The amount, as it can be dose dependent. It is also important to find out whether this is the first exposure or has prior tolerance. You also want to find out what are the signs and symptoms. Okay, are these consistent with food allergic reaction or suggestive of anaphylaxis? Okay, the characteristics of the rash are usually quite important because if let's say this is a case of food allergy, usually it is itchy and bothersome. Okay, you also want to identify and clarify if there is any reproducibility of symptoms with re-exposures. Also take note that sometimes allergic reactions can be triggered by physical contact or inhalation aside from direct consumption. So if the duration of the rash is prolonged, days to weeks, and not itchy or bothersome, with intercurrent respiratory symptoms, then the rash is likely due to intercurrent viral infection. Now, going back to the 2 cases earlier that I showed you guys earlier, based on the clinical history itself, the former case is likely to have egg allergy, and skin testing and IG testing would likely to be confirmatory. In the latter case, it is unlikely to be egg allergy, and the urticaria is most likely to be related to the intercurrent viral infection. Thus, further allergy testing is not necessary. In food-induced anaphylaxis, it is also good to identify in the history if there are any cofactors, such as infection, exercise, stress, sleep deprivation, dehydration, or NSAID use that may have lowered the reactivity threshold. Now let's go back to case 1. How would you further evaluate this patient? Let's start the poll, Deborah. So number 1, would you obtain further diet history? Number 2, perform skin prick test and specific IgE food panel. Number 3, perform food and eczema IgE panel. Number 4, perform IgG food panel. Let's start the poll and we will stop in a short while. Okay, can we stop the poll? Okay, so majority will perform the skin prick test, skin prick and IgE to food panel. Some will do food and eczema IgE panel. Some will obtain further dietary history. Now, these are some of the indications that you should consider before utilizing these diagnostic tools, such as skin prick test or serum-specific IgE. Number 1, when there is convincing history of IgE-mediated allergic reaction after a specific food exposure. Number 2, for monitoring of disease. Number 3, for screening of infants with severe eczema refractory to optimal eczema treatment. Both skin prick tests and specific IgE tests are good with fairly similar diagnostic performance. They are highly sensitive but not specific. The rate of false positive is up to 40%. Skin prick test is quick and simple to perform. It is safe and the results are prompt, usually obtained within 15 to 20 minutes. It is also cheaper compared to IgE tests. However, it can only be performed by trained personnel and on infants who are at least 4 months of age. Specific IgE is safe and can be performed at any age. It is more invasive as it requires venipuncture and may not be as acceptable as skin prick for some caregivers. It is also rather expensive and takes approximately 2 weeks for the results to return. At KK, skin prick test remains the first line of investigation that we perform for children with suspected IgE-mediated food allergy, except if the child has eczema flare where SPT cannot be done. Food allergy testing is only diagnostic within the context of a consistent clinical history of reaction. When allergy test is performed, it should be as narrow as possible. Preemptive or broad panel testing in the absence of convincing clinical history has high potential to overdiagnose food allergy, resulting in unnecessary food avoidance. As these tests have poor specificity, they are not intended to be used as screening tool to determine if a patient has food allergy, and this may consequently increase the risk of true food allergy by unnecessary avoidance and delaying food introduction. Exception is when you have a young infant who had just started weaning and was only tried on one food allergen with an allergic reaction to the specific allergen. Then it is okay to perform skin prick test food panel to the other common allergens prior to introduction of new food due to the associated risk of other food allergy in this patient. Skin prick tests of fresh food using prick technique are sometimes used when there is discrepancy between a clinical history and skin prick test results to a commercial extract, or when a specific food extract is not available. This is performed by applying the lancet on the fresh food followed by pricking onto the skin. For example, in a child with convincing clinical history of sesame allergy and skin prick test to sesame commercial extract is negative, prick test to tahini may be performed to establish the diagnosis. In patients with suspected kiwi or banana allergy, whereby a commercial extract for skin prick is not available in our clinic, prick tests to the fresh food are done to confirm the diagnosis. Intradermal test or atopy patch tests are not recommended in the diagnostic evaluation of food allergy. Back to case 1. You obtain further dietary history from the mother. The reaction to egg occurred at 8 months old, and since then, mother had been very cautious with introduction of new food to him. He is taking NAN Optipro formula 120 to 150 ml 4 times per day, with 2 solid meals a day consisting of porridge, vegetables, fish, and chicken. She has not introduced any other major food allergens into his diet for the fear of reactions. This is his skin prick test result. A positive SPT is when the mean wheal diameter is 3 millimeters or more than the diluent wheal size. So, in this case, the egg skin prick test is not surprisingly positive. It is 5.5. But incidentally, the skin prick test to milk and peanut are also positive, with milk of 3 and peanut of 4. Generally speaking, a positive serum-specific IgE is when it is more than 0.35. Interpretation of the classes of specific IgE class 0 to 6 is not clinically useful in diagnosing food allergy. As you can see for this patient, his specific IgE to egg white and peanut are both positive. Now let's look at how we can interpret these allergy test results, linking the clinical history together. With a convincing history of IgE-mediated allergic reaction coupled with an evidence of sensitization, either positive skin prick or IgE, a clinical diagnosis of food allergy can be made and the patient should avoid the food. If there is no prior exposure and the skin prick test or IgE is positive, this indicates sensitization. Further evaluation with diagnostic food challenge is required to determine if this sensitization is clinically relevant. If there is regular consumption of the allergen in food amounts with no reaction, and the skin prick test or IgE is positive, the patient is considered clinically tolerant. This just demonstrates that the patient has immunological feature, but not manifesting a clinical disease, and he should continue taking the food. So for patient in case 1, he has egg allergy, peanut sensitization, and is cow's milk tolerant. He needs to avoid egg strictly, but can continue taking milk and dairy products regularly. Further evaluation with diagnostic OFC to peanut should be considered. The negative predictive value of skin prick tests and specific IgE is high, more than 95%. Therefore, a negative skin prick or IgE generally confirms the absence of IgE-mediated allergy, and food avoidance is usually not necessary. Another point that I wanted to highlight is that a positive skin prick test or IgE test does not equate to clinical food allergy, especially in the absence of a clinical reaction. A strong positive results are more likely to be clinically relevant. However, it cannot be used to predict the severity of reaction. Different food will have different cutoffs as their 95% ppb. Above these cutoffs, we would be 95% sure that the child is allergic to the food and should avoid the food. However, there is a gray zone where the result is considered positive, but below the 95% ppb cutoff. In this case, we are none the wiser. There's a chance the child is allergic to the food, but there's also a chance that the child could possibly be tolerant to the food. In this case, further evaluation, including food challenge, is required to establish a diagnosis. This paper reported the 95% ppb for food-specific IgE for 6 major allergens. As you can see, the values for each food allergen can be very variable, ranging from 7 in eggs to 80 in wheat. Where skin prick tests or specific Ig tests are inconclusive, component resolved diagnostic may provide additional diagnostic information and improve diagnostic accuracy. Component testing measures IgE sensitization to major allergens, and these are over-mucoid for egg, casein for milk, omega-5 gliadin for wheat, ARA-H2 for peanut, GlyM8 for soy, ANA-O3 for cashew, CORE-A14 for hazelnut, JAR1 for walnut, CES-I1 for sesame, and FAT-A3 for buckwheat. Oral food challenge, particularly double-blinded placebo control, remains the gold standard diagnostic test for food allergy. There are several protocols that are being used internationally. At KK, our food challenge protocol for IgE-mediated food allergy is based on Practor consensus. It is usually carried out in a graded manner, starting from an initial dose of 3 mg titrated up to final dose of 3 grams of food protein, with time intervals of 15 to 30 minutes between doses. Double-blinded placebo control OFC can be considered in patients with subjective or atypical presentation or for those who are anxious. The food should be blinded for taste, smell, texture, and appearance. OFC is typically performed to confirm the diagnosis when the skin prick or IgE tests are inconclusive with a suggestive clinical history. It can also be used to determine the threshold dose of a causative allergen. OFC can also be performed to ascertain tolerance in patients who are suspected to have outgrown their allergies, or to ascertain big product tolerance in egg or milk allergic patients. It can also be used to monitor response to immunomodulatory treatments such as OIT. However, OFCs are usually labor-intensive, time-consuming, and costly. It also carries the risk of anaphylaxis and is not foolproof, with 3% false negative and 3% false positive rates. This is our food OFC setup at KK Hospital. The next one will be basophil activation test that I will just cover briefly over here. It is a novel and sophisticated allergy test that has gained much attention over the recent years. It is an in vitro functional assay that assesses the expression of activation markers on the surface of basophils by flow cytometry following stimulation with food allergens. It has been shown to be an effective biomarker in the diagnosis and monitoring of food allergy with higher specificity and negative predictive value than skin prick or IgE. However, it requires a specialized laboratory setting, labor-intensive, and it is not widely available. Thus, the use of this promising test is still limited to research purposes. Now, let's move on to mixed and non-IgE-mediated food allergy. Unlike IgE-mediated food allergy, the symptoms of mixed or non-IgE-mediated food allergy are typically delayed from hours to weeks after ingestion of the culprit food. Food protein-induced allergic protocolitis usually presents in early infancy, days to 6 months, with intermittent mucus-laden bloody stools in otherwise healthy, thriving infants. Common triggers are milk and soy. They typically resolve spontaneously by age of 1. F-PIES typically presents with acute repetitive profuse vomiting with pallor, with or without lethargy, 1 to 4 hours post-ingestion. They may also have diarrhea 5 to 10 hours post-ingestion, and about 15% may progress to hypovolemic shock. Common triggers are milk, soy, rice, oat, wheat, and fish. Majority of F-PIES are caused by single food, usually cow's milk or soy. About 25% react to 2 foods, while less than 10% to 3 or more. In F-PIES, development of tolerance in cow's milk-induced F-PIES occurs earlier than grain or solid food-induced. Food protein-induced enteropathy FPE is uncommon and typically presents with chronic intermittent vomiting, diarrhea, or hypoalbuminemia or failure to thrive. Eosinophilic esophagitis, EOE, is a rare entity of mixed IgE and non-IgE-mediated food allergy. Patients typically present with intermittent vomiting, abdominal pain, dysphagia, feeding difficulties, or failure to thrive. EOE symptoms can often overlap with symptoms of gastroesophageal reflux disease, leading to delayed diagnosis. Common triggers are milk, soy, egg, and wheat. Mixed and non-Ig mediated food allergy are definitely much more challenging to diagnose than Ig mediated food allergy. Non-Ig mediated food allergy are diagnosed mainly based on clinical history, as there is lack of validated diagnostic biomarkers. The absence of specific IgE is an expected characteristic feature of non-Ig mediated food allergies in children. Thus, skin prick and Ig tests are usually negative in these patients. The cornerstone for diagnosis remain as strict elimination diet for 2 to 4 weeks with symptom improvement or resolution, followed by reintroduction with recurrence or worsening of symptoms, except for those with convincing history of FPIs or severe symptoms, when reintroduction may not be possible due to its high adverse risk. The diagnostic elimination diet should ideally be implemented with the support of a dietitian with careful consideration of reintroduction into the diet in the form of food challenge if necessary. It is imperative to exclude other common causes first, such as infection or structural causes, before considering the diagnosis of mixed or non-IgE food allergy. EOE is a chronic inflammatory disease caused by infiltration of eosinophils in the esophageal mucosa in absence of other causes of eosinophilia. Majority of these patients with EOE are often affected by one or more atopic conditions. Diagnosis is usually made via upper endoscopy and esophageal biopsies, demonstrating at least 15 intraepithelial eosinophils per high-powered field. Now, doctor, my child has eczema. Can you run allergy tests on him? This is a commonly asked question in the clinic, and in many of these children, multiple foods are often excluded from the diet due to caregivers' concern that food allergy is causing the eczema. Parents often request for child to be tested for food allergy. What would you do? Firstly, it is important to understand the pathophysiology of eczema. Epithelial barrier dysfunction is a hallmark of eczema and is attributed by a combination of structural, genetic, and environmental factors. The postulated pathogenesis of eczema include the inside-out theory, whereby immune dysregulation triggers the T helper 2 inflammatory response that disrupts the skin barrier. Outside-in theory, whereby impaired skin barrier allows the penetration of allergen, irritants, and microbes through the skin, leading to a cascade of inflammation resulting in the eczema. Now, does food allergy really cause eczema? There is a strong causal relationship between eczema and food allergy, where approximately 1/3 of infants with moderate to severe eczema have food allergy. Our skin is constantly exposed to environmental allergens. In those who have genetic predisposition to allergic diseases, such as Willer-Green spin 5 gene mutation, these factors lead to skin barrier dysfunction. Skin barrier impairment leads to skin inflammation and progression into clinical atopic dermatitis. Exposure of food allergens through skin that has disrupted barrier or has clinical atopic dermatitis leads to epicutaneous sensitization and development of food allergy. Hence, it is important to note that food allergy does not usually cause eczema. Eczema, especially when it's poorly controlled, is the precursor to food sensitization and the subsequent development of food allergy. Hence, for patients with eczema, the mainstay of management is optimization of eczema therapy with topical emollients and topical steroids, or TCI. In a small subset of infants with refractory, moderate to severe eczema, trial of elimination diet can be considered if food allergy is suspected. If trial of elimination diet is to be employed, the duration should be brief, 2 to 3 weeks, and to be followed by reintroduction via a supervised food challenge. Allergy testing should only be considered in infants with severe eczema with recalcitrant atopic dermatitis despite aggressive topical treatment, or those with history compatible with immediate IgE allergic reaction. In these patients, careful selection and limited testing to relevant allergens can be performed in order to avoid unnecessary allergen avoidance and inadvertent nutritional risk. And yes, avoidance diet can harm. Okay, elimination of food in a young child with eczema can result in nutritional deficiencies leading to faltering growth. It can also lead to delay in development of feeding skills in young infants. Removing foods from the diet also requires attention to label reading, caution during eat-out, home and school management, all of which can lead to significant impact in quality of life and misdirection of treatment away from the skin. Another harm that many are not aware of is the potential of progression from a tolerant or sensitized state to a true food allergy after a period of avoidance. Thus, decision for elimination diet should not be taken lightly and should be guided by a trained clinician and dietitian with clear diagnostic or therapeutic goal in mind. This is a concise algorithm illustrating a pragmatic approach in the diagnosis of patients with suspected food allergy. Before I end my talk, these are some of the expensive diagnostic alternative tests that are commonly being promoted to clinicians in the evaluation of patients with suspected food allergy and should be avoided. These include bioresonance tests, kinesiology, IgG and IgG4 tests, Vega test, hair analysis, and iridology. These tests are not currently validated and are not recommended. Now, this comes to the last slide of my talk. These are some of the key messages I would like to highlight to you today. Point number 1, IG-mediated food allergy is rapid in onset, usually within minutes to 2 hours after exposure. They present with mucocutaneous symptoms, respiratory symptoms, severe symptoms, or anaphylaxis. Detailed clinical history is crucial in the diagnosis, and allergy testing should only be done when there is convincing clinical history. It is also important to select and interpret the allergy test carefully to avoid unnecessary food avoidance. Please remember to select relevant allergens for testing rather than a preemptive or broad panel. Point number 2, mixed or non-IG mediated food allergy are typically delayed in onset from hours to weeks after ingestion of the culprit food. They are challenging to diagnose with no validated biomarkers available. Rule of thumb in diagnosing this group of conditions are by empiric elimination diet for 2 to 4 weeks with symptom improvement or resolution, followed by reintroduction with recurrence or worsening of symptoms. The diagnostic elimination diet should be implemented with the support of dietitian if it's deemed necessary. Before I end my talk, I would like to acknowledge the amazing KK team whom I have the honor of working with. Thank you, Kok-Wee and ACIS committee for giving me this opportunity to speak today, and thank you, Hui-Hun, for the beautiful pictures that I've used for the talk today. Thanks, everyone.
Thank you, Samantha, for clear and informative insights on the manifestation and diagnosis of food allergy in children. Next, I would like to introduce Dr. Lydia Wong. Dr. Lydia Wong is currently a consultant pediatric allergist in the National University Health System. Without further ado, I would like to invite Dr. Wong to deliver a talk on management of food allergy in children. Pass to Lydia.
Hi, sorry, just looking to share my screen.
Yeah.
Okay.
Okay, I would also like to encourage participants to type your questions, Q&A questions in the chat box. So our panelists are happy to address all the questions. And you have a question for Dr. Lee, you can also type it on the chat box. Thank you.
Okay, hi. My name is Lydia Wong. I'm a consultant in the Division of Allergy in NUH, and I think we'll get right into it. So I'd just like to start with a small case vignette. This is an 8-month-old with egg allergy, and I think the reason both Samantha and I chose to present infants with egg allergy is that this is just the most common clinical scenario that we get, because egg allergy is the most common IgE-mediated allergy, and it typically presents at the age that you introduce egg. So she developed perioral hives and angioedema after taking ice cream for the first time for her father's birthday at a buffet restaurant. And she regularly takes formula milk, which is S26 milk. I checked whether it was a hydrolyzed milk, as a small number of my cow's milk allergic patients actually do not react to partially hydrolyzed formula, although the majority of them will still react. And we confirmed the diagnosis with a skin prick test, where the egg white skin prick test was positive, 10 by 3 millimeters, and the egg yolk of 8 by 4 millimeters. So if you ever see two numbers together, that's because they're actually taking the two diameters of the skin prick test wheel, and then you can take the mean of this. And as Samantha has very nicely gone through, and skin prick test of 3 and above is typically considered positive in the appropriate clinical context. So mother then emailed the restaurant and confirmed that this ice cream that the child was exposed to contains egg, because not all ice creams contain egg. And so there's the diagnosis, most likely egg, we confirmed the diagnosis of egg allergy, but since then they're avoiding all new foods because they are now afraid that she has allergy to other foods. So what should we do next? So we actually did skin prick tests to all the other foods that she had been avoiding to guide the parents in their introduction of other foods. So cow's milk caused 0. The peanut and tree nut panel, she hadn't introduced any nuts at all, was also negative. Soy and sesame were negative. Wheat, kiwi, because she had taken, I think, a bite of kiwi tart at the dinner as well. And she was advised to introduce other allergenic foods. And the reason why we have been giving this advice and taking the time to skin prick test her to all the other allergenic foods is that there's a lot of data now from sort of paradigm-changing data from large interventional randomized control studies, which demonstrate that the early introduction of allergenic foods will reduce the risk of sensitization and food allergy. And one of the largest studies was the LEAP study, which was published in NEJM in 2015. And you can see in this table here that in the group of babies who high-risk infants who ate 2 grams of peanuts 3 times a week, only 0.3% of them developed peanut allergy compared to 17.3% of the cohort that avoided peanuts. Does this work for other allergenic foods? So there was another study which examined this, the Petit study in The Lancet, which was published in 2017. Egg allergy was present in 4% of the high-risk infants who ate heated egg powder daily versus 38% in the placebo group. So, what are the allergenic foods that we're speaking about? Just as has been said by the previous speaker, these are the big 8. These 8 foods cause 90% of IgE-mediated food allergy in children. First egg, followed by milk, then peanuts, tree nuts, wheat, soy, fish, and shellfish. But shellfish typically presents a bit later, especially in our Singaporean cohort. So she was advised to introduce other allergenic foods, and this advice is the general advice we give for prevention of food allergy from the age of weaning in an appropriate form. And this typically means in a form that does not induce any risk of choking. So, sort of hard-boiled egg and peanut butter, very smooth peanut butter. And this is a poster that is put out by the the Canadian Society of Allergy and Clinical Immunology and Food Allergy Canada, which I believe is an advocacy organization to eat early and eat often. Okay, so there's also the definition of high risk. What is it? Who is at high risk of developing food allergy? So these are defined as infants with existing history of eczema or with pre-existing food allergy. So a child who is egg allergic is at higher risk of developing other IgE-mediated food allergies. Or an immediate family member with atopy, meaning allergy, allergic rhinitis, asthma, eczema, or food allergy. Okay, so the principles of food allergy, number 1, get the right diagnosis, and that's already been covered. The next is to eat what you can, because for children with egg and milk allergies, the regular consumption of baked egg and baked milk will help to increase the number of foods that you can eat in your diet and may hasten tolerance. Avoid what you cannot eat, so patient education and avoidance, recognize and treat complications, monitor for resolution. There's very exciting new treatments for food allergy, such as oral immunotherapy. And just a final note on who should be involved in the management of food allergy. Okay, so one question the parents had for me after that was, do we need to avoid egg as an ingredient? So she can't eat eggs. Can she eat things that contain eggs, like cakes and muffins? Because they noticed that they had relatives or friends whose egg allergic children could tolerate egg in some forms. So 80% of milk or egg allergic children can tolerate baked goods which contain egg and milk. And why is this? It's primarily due to the effect of thermal processing on epitopes. And we know that epitopes are the portions of antigenic molecules that bind with the complementary site of the antibody. So if you look at this diagram on the right side, you can see that this is the protein. It's all folded up. And the epitope may be a sequential epitope, or it could be a conformational epitope. So for conformational in epitopes, so some types of conformational epitopes with heat labile bonds are quite sensitive to thermal processing. And if the protein is heated to a certain degree of heat at a certain amount of time, these heat labile bonds actually will become destroyed and fragmented, and then the epitope becomes fragmented and it does not bind to the IgE. And this is the reason why egg allergic children can tolerate baked goods which contain egg and milk. So this is a diagram showing some of the many allergenic proteins inside cow's milk and hen's egg. So if you look at cow's milk, there are two major classes of allergenic proteins, which are caseins and whey. And by and large, whey proteins are heat labile, so they are affected by thermal processing. If you put milk into a muffin and then you bake it, most of the whey protein will be affected by this processing, whereas casein is typically heat resistant. And the same goes for the hen's egg allergens, where ovalbumin is heat labile, whereas ovomucoid is relatively heat resistant. So we're now able to measure specific IgE to some of these components as well. So we could measure their casein specific IgE or their ovalbumin and ovomucoid specific IgE, and that can give us information, prognostic information on whether these children are likely to tolerate baked egg or baked milk, but the majority of them do. So we know that if you are able to eat a muffin containing baked egg or milk, that you have a much higher chance of outgrowing your egg or milk allergy. So it's still unresolved whether the regular consumption of baked egg and baked milk actually has an effect on the development of eventual tolerance, or does the tolerance of baked egg and baked milk merely represent a milder phenotype of egg and milk allergy with a favorable natural history? I think the final word on this is yet to be delivered. It's quite difficult to study in a very rigorous manner, although there are definitely a lot of studies going on. But there are many good and practical reasons to introduce this, such as increasing nutrition, allowing for a larger source of foods into the diet, for enjoyment of food, for social reasons, and also because there's a very real chance that it may help the child to develop tolerance to the egg or milk a little bit earlier. Okay, so how do we do this on a practical term? So there are various egg and milk ladders available. I've just put a more simple one over here, and you can see that in step 1, these are very well-baked goods such as muffins or cupcakes or a well-baked cookie. And then it moves on to baked goods which are less baked. So in comparison to a muffin, which is typically about 160, 170 degrees Celsius, 20 to 30 minutes. A pancake or crepe may only be heated for up to 5 minutes on the stove. And if it's a waffle, if you think about it, it's usually less than 5 minutes inside the waffle maker. And then after that, by step 3, you're going up to fully cooked egg, which most patients will tolerate before they are able to tolerate partially cooked eggs, such as the soft-boiled egg or lightly scrambled egg. And finally, tolerance of raw egg is typically the last thing to develop. So in real life, what we would do in the allergy clinic is to describe this to the parents and to book them in for a baked egg muffin challenge. And it's just an example of the recipe that we give to the parents. We try to standardize the amount of egg. So standard risk would be about 1/3 egg per muffin. So we give it to them, and unfortunately our kitchen in NUH cannot really accommodate us in terms of preparing the muffin. So we get the parents to bring the muffin. Sometimes parents say they're not bakers, so then we'll tell them that they can bring something that's from a bakery, but they need to check the ingredients and make sure egg is at least one of the first third ingredients, as ingredient lists typically list the ingredients in proportion. So this is an example of a milk ladder, and the principle is roughly the same. So starting with a very well baked good, such as a muffin, cupcake, or cookie, and then moving up to less baked goods. So we would challenge at this point to demonstrate tolerance to a baked good with milk. And then another challenge either with boiled milk or pizza, or just directly to unheated milk protein itself. So this ladder actually is quite well known, and I think there's sometimes a little bit of confusion. So I have had some family medicine colleagues or trainees and medical students who ask me about the use of a milk ladder at home. So the milk ladder, if you can see the small print over here, is actually for home introduction, but it does say that it is only to be used in children with mild to moderate non-IgE cow's milk allergy. So the question of whether milk ladders or egg ladders can be done at home I think there are a few considerations. Number one is that 20% of milk and egg allergic children still react to baked goods which contain egg or milk. Reactions can be severe, delayed, or with less mucocutaneous manifestations. Even if the majority do not react, you can get anaphylaxis to egg muffin. Can we predict those who will tolerate? So there are SPT and specific IgE cutoffs that have been evaluated. However, the negative predictive and positive predictive value are not foolproof. And I think they're quite dependent on the cohort, whether it's a general population cohort or cohort seen in an allergy clinic, and dependent on the geographical variation as well. Certainly, if there's a significant sensitization, large SPT wheels, more than 10 millimeters, and high specific IgE to heat-resistant components such as casein and ovomucoid, these are associated with a low chance of passing a baked egg or a baked milk challenge. Okay, so home introduction by parents is safe in mild non-IgE mediated allergy like cow's milk protein allergy proctocolitis. I think that will be actually quite safe for parents to try at home, or in food triggers and eczema with prior tolerance of food, where you know that the child has been eating the food regularly and has never had an IgE mediated reaction, and you do a period of exclusion, so then you can reintroduce. Recommended for supervised setting under allergist guidance would be all cases of IgE-mediated food allergy, as well as severe non-IgE-mediated allergies such as food protein-induced enterocolitis syndrome, eosinophilic esophagitis, or cow's milk enteropathy. Okay, I'll just move on. So this 8-month-old had a baked muffin challenge with the standard recipe, about 1/3 egg per muffin. They did it at about 11 months old because that's when they felt that she would eat enough of the muffin to really be able to tell, and passed. So now she's regularly eating muffins, cakes, and other fully baked goods that contain egg as an ingredient. She could eat her cake for her birthday, so they were very happy. I did warn parents that you must be sure not to get cake with buttercream or icing, as these contain non-baked egg. And I do have patients who react to the non-baked components of the cake, even though they can eat the cake. So what about the egg itself? So allergen avoidance is obviously a very large part, or the mainstay of food allergy management once you've got the diagnosis down and introduce them onto the baked forms. So we do need to educate them on label reading. Label reading can be quite complicated. It's not always used in plain language labeling, although there's a big push now for food allergy labeling to be very clear. But egg may be labeled as dried egg, egg powder, ovomucoid, ovalbumin, lecithin, lysozyme. We have had a patient who had anaphylaxis, an egg allergic patient who had anaphylaxis to lactose, unfortunately, because it contains lysozyme. And hidden allergens are common, especially when dining out or in processed food. We have had patients who reacted to tree nut in curries. In certain restaurants, it can be used, nut powder can be used as a thickener for curries. Pesto is typically made with pine nuts, but in some processed pesto, it's made with cashew. I've had a patient who had anaphylaxis to the Impossible Burger because it contains coconut. It can be used as a binder in hamburger patties, and you can even find trace amounts of milk solids in fruit juice. And quite a lot of egg allergic patients somehow don't forget that mayonnaise actually contains egg. So the next question she had as she came up to 12 months old was about vaccination. So can egg allergic patients get the MMR or influenza vaccine at the clinic? And she was actually asked by the clinic nurse, to just check because she was egg allergic. So the answer to this is yes. MMR vaccines are actually produced with cell cultures from chicken fibroblasts and contain no egg protein. Influenza vaccine contains a very small residual amount of ovalbumin, less than 1 microgram, and the amount needed to induce a reaction is about 130 micrograms. So several published reviews, guidelines, and reports suggest no increased risk of anaphylaxis associated with influenza vaccination of people with egg allergy. And a 2012 review of published studies included 4,000 plus egg allergic patients, including 513 with a history of severe egg allergy, with no cases of anaphylaxis occurring after receiving influenza vaccine. So this is consistent with guidelines from American and Australian academies. No special precautions are required regardless of the severity of egg allergy for MMR or influenza. Is there any vaccine for which you need to worry about your patient with egg allergy? So yellow fever and Q fever vaccines contain higher amounts of egg protein. If you have an egg allergic patient who needs one of these vaccines, please send them to the allergist. We can usually vaccinate them, but we may do some preemptive skin testing with the vaccine. So this is just to emphasize the point that SKL guidelines for vaccination of the egg allergic patients suggest that, just actually state very firmly that egg allergic patients may be safely vaccinated. Special precautions such as split dosing, prior skin testing, allergy specialist review, or prolonged waiting times after administration are not required. And this is the practice parameter from the American Academy, which states that vaccine providers and screening questionnaires do not need to ask about the egg allergy status of recipients of influenza vaccine. Okay, so next we'll move on to recognizing and treating allergic reactions. So of course, one of the most important things is to teach them how to recognize anaphylaxis. This is the action plan that we give out to the patients and their families, we'll just, I think the definition of anaphylaxis we've gone through already in the first talk. So we also emphasize to parents that in young children, sometimes they just look pale and floppy, and they just go very quiet for a while. And this can be a manifestation of anaphylaxis in a young child. So action, give EpiPen. We tell them to call the ambulance. I think this point about laying the patient flat, elevating the legs is sometimes less well recognized, but it's actually very important to avoid any change in any postural changes, as this can affect the hemodynamic stability of the patient. So I have had patients who had anaphylaxis, they sat down, they gave themselves the EpiPen, and they looked so much better by the time the ambulance arrived that the paramedics actually suggested they get up and walk, at which point the patient just fainted. So they should not move. They should lay flat and elevate their legs. They should be allowed to sit. They should be transferred by stretcher to the ambulance. And of course, we always use the EpiPen training device to teach them how to use the EpiPen. So we also have a video that we've prepared, and our newest action plan has a QR code that they can scan. So we try to get our patients to bring it back and get their family members, caregivers, because it's usually more than the parents. In Singapore, we usually have the school, domestic helpers, grandparents, our aunts and aunties who also take care of the child. I've just put 2 screenshots from the video itself that show how to administer the EpiPen to a young child. It is an auto-injector with a needle, so there's a risk of laceration injuries, especially if the child is struggling or the parent is very afraid and not sure of how to use it. So in this screenshot up here, the nurses are demonstrating how to use the EpiPen if you have two people. So one person will restrain the thigh of the child, and if you're alone, you can try to immobilize the legs of the child, and when you put the EpiPen into the lateral thigh, as you can see here. Okay. So we also provide letters to the school, as well as school teaching on anaphylaxis treatments and the use of the EpiPen. Travel letter for EpiPen and antihistamines if they're traveling. Some people use allergy bracelets, allergy cards, and this is one example of an allergy card. And we encourage them to teach the child as children get older to read labels and to ask whether their food contains allergens, and for the child to also recognize when they're having an allergic reaction. Just briefly go through one important aspect, which is the nutritional management of food allergy. This is an 8-year-old boy, my patient, who had cow's milk and egg allergy. And as you can see, he is quite underweight, below 3rd centile for weight, although he is on the 25th centile for height. Who is at risk for nutritional deficiency? Cow's milk, wheat, or multiple food allergies have the greatest impact. Children with milk allergy or multiple food allergies are also more likely to have inadequate calcium and vitamin D intake. And children with food allergies who receive nutritional counseling had better nutrient, calcium, and vitamin D intake. So these are other indications of increased nutritional risk in children with food allergies. So the parts that are also important here to highlight is a picky or self-selective eater, delayed introduction of solid complementary foods, feeding delays or difficulties, and medical or psychological diagnosis affecting dietary intake. This is just a chart demonstrating the effect on nutrition with elimination. So if you can see in the first column, typical diet here would be 2,500 calories. And if you eliminate sort of the 6-7 most common food allergens, you're actually down to about 600 calories. And then with substitutions, you can get it back to the previous amount. But obviously, all these substitutions, they do have a significant expense, and you need advice on how to find appropriate substitutes. So we do involve our dietitian colleagues in these patients, and nutritional assessment by the dietitian is now recognized by several international guidelines as essential to monitor growth, ensure nutritional adequacy, and educate and support parents on avoidance as well as food alternatives to replace the nutrients eliminated. When to refer to the dietitian, faltering growth, sometimes, especially in the weaning diet, especially for my infant patients with multiple food allergies, egg, cow's milk, wheat, micronutrient deficiencies if they're picked up, or feeding difficulties, as a lot of our patients with severe atopy, severe atopic dermatitis, or IgE-mediated food allergy often have feeding difficulties as well. Okay, so the mechanisms by which food allergy resolves are not fully understood, and multiple mechanisms are probably involved. So this is always the question parents have, whether this will be for life or is she going to grow out of the food allergy. The loss of food-specific IgE is the best known predictor for the development of clinical tolerance. However, some patients do become tolerant even with persistently elevated specific IgE or positive skin prick test. Serial testing is required with evaluation by either skin prick test or SIgE at regular intervals. Typically, we do this yearly, but it is also dependent on the allergen as well as the age of the child. Sometimes in a very young infant with egg or milk allergy, I'll do it as early as 4 to 6 months later. For tree nuts, it doesn't change that fast, so we usually do it yearly at the most. Loss of sensitization is not conclusive, so we can't just have a skin prick test that has become negative and say, go ahead and eat the food. So, or we still need a diagnostic oral food challenge. And as we mentioned in the first talk, non-IgE mediated food allergy sensitization is not helpful, and an oral food challenge is necessary to confirm the development of tolerance. So what is the natural history of IgE-mediated allergy? So this is a nice table from a very widely quoted paper of the typical allergenic foods. A lot of the figures for the rate and age of resolution are from Australian data or US data. So I do think that for our Singaporean cohort, we have slightly better prognosis, especially for egg and milk. Typically, we'll say that 80% of milk and egg allergic patients resolve by the age of 5 years. For peanut, it's about 20 to 25%. Tree nuts, probably around 10 to 15%. The majority of wheat and soy allergies will resolve. Prognostic factors are typically related to peak specific IgE. So persistent high levels of sensitization are associated with a poor prognosis for resolution. And for egg and milk, the tolerance of baked egg or baked milk suggests a good prognosis. So peak SIgE levels do affect the rate and percentage of resolution. And if you can just look at the graph in A, you can see that for the brown line, which is the top line, these are for patients who had peak SIgE levels of more than 50. for cow's milk IgE, and at the age of 18, only about 40% of the patients had outgrown their cow's milk allergy, and about 60% had persistent cow's milk allergy, which is very different from the lowest level, which is for the patients who had peak SIG levels of less than 2. And by age 16, perhaps only 4 or 5% of them still had persistent cow's milk allergy. What about non-IgE mediated allergy? For FPIEs, milk and soy FPIEs resolve in the majority of patients by 3 years. For solid food FPIEs, there's typically a more protracted course. For egg, anywhere from 3 to 5 years, and rice, 3 to 5 years as well. What factors are associated with the slower acquisition of tolerance? Detectable specific IgE, because most don't have it, or an older age at initial episode. General recommendation is to repeat challenges 18 to 24 months after no reactions. And for cow's milk protein enterocolitis, this typically resolved by the age of 1 year. So finally, there's a new hope on the horizon, which is oral immunotherapy. This is a medical treatment by which a food allergic individual consumes an increasing amount of the allergen with the goal of reducing the risk of allergic reactions to the food. And this is a brief diagram showing the process. There's an initial dose escalation day, followed by an updosing phase every 2 weeks, where you come into hospital for the updose, and then you stay on that same dose for the next 2 weeks, and 2 weeks later, you slowly updose until you reach the maintenance phase, and where the child will eat a small measured amount of the food allergen regularly, typically anywhere from daily to at least 2 to 3 times a week to maintain the desensitization. So benefits of oral immunotherapy: the ability to induce desensitization and improve the quality of life through reducing dietary limitations, social restrictions, emotional impact, anxiety, and to improve nutrition, and to provide some partial protection against accidental reactions by raising the threshold of reaction. What are the pitfalls of OIT? There is limited ability to induce permanent tolerance, meaning that if the child, even after completing OIT to the maintenance phase, if you stop eating the allergen for a period of time, you will lose the state of desensitization. There's an increased risk for allergic reactions. So a person who completely avoids peanut may have something like a 4% or 7% risk of allergic reactions, and that will obviously increase if you start OIT. There is a need for regular long-term consumption. The failure rate can be anywhere from 10 to 35% due to significant allergic reactions. And in some cohorts, they have reported a relatively high long-term dropout rate. Nonetheless, this is increasingly recognized as a very viable and generally quite safe method of treatment for patients with food allergy. And it received FDA approval for palforzia, which is a form of peanut oral immunotherapy. Essentially, it's a purified form of peanut protein that is packaged into capsules. So this was FDA approved in 2020. And this is just a diagram to show the difference between sensitization, desensitization, and tolerance. So OIT will get you to here, somewhere in between, but we have not been able to induce permanent tolerance. So what you get is not the same as growing out of a food allergy. So I just want to share one slide on the NUH experience with OIT. So this was from a study published by Dr. So Tian-Yi, who was the physician who started the OIT program in NUH, and my colleague. And a brief run through of the study protocol, where we started with updosing of the peanut flour. We had a maintenance phase. And because this was a research protocol, there was an optional 4-week abstinence from peanut, and then followed by regular intake of peanut containing food. So 77% completed maintenance therapy. There were a few dropouts due to allergic reactions, and there were no episodes of anaphylaxis. At the 3-year follow-up, 80% of responders were still consuming peanut regularly. And since then, we have treated more than 100 children with clinical OIT, where there's no period of abstinence. So currently, we offer the following foods for oral immunotherapy at NUH with the age cutoff of 5 years and above. So we do peanuts, tree nuts, which is almond, cashew, pistachio, macadamia, walnut, pecan, and Brazil nut. Wheat, we do egg and baked egg OIT, milk, and sesame. So what can the allergist do for your patient with food allergy? So we can confirm the diagnosis. We guide the introduction of other allergenic foods to reduce the risk of development of other food allergies, safely introduce big forms if tolerated, patient education on avoidance and treatment, follow-up and monitoring for resolution, and if needed, multidisciplinary care with a dietitian and psychologist. And of course, we can speak to them about oral immunotherapy and consider that as an option for persistent food allergy. And just put in here assessment of food sensitization in patients with eczema. And take-home points, correct diagnosis is important. We aim to introduce other foods early if not allergic. Baked milk, egg, and milk, if tolerated, should be consumed regularly and may hasten eventual tolerance. Patient education is essential. Majority of egg, milk, wheat, and soy allergies resolve. Majority of peanut, tree nut, and shellfish allergies persist. Follow-up and serial testing for resolution of sensitization helps determine optimal timing of food challenges to confirm tolerance, and oral immunotherapy is a promising new treatment for food allergies. Thank you very much. This is a picture of our NUH allergy team, to which I'm very grateful, and we have to have this experience of helping our kids with food allergy, and a picture of our day therapy unit. Very happy to take any questions later, and I'm very happy for you to email me with any patients or with any questions that you have.
Thank you very much, Lydia, for such an in-depth look at management of egg allergy. Next, I would like to invite Dr. Samuel Lee to give his next talk. Dr. Lee is a consultant in Tan Tock Seng Hospital and training in allergy and clinical immunology. He's a treasurer of the Allergy and Clinical Immunology Society Singapore and is also involved in our gastro-allergy cohort study. Dr. Lee is going to present some interesting cases of food allergies in adults. Dr. Lee, please.
Hi, I hope everyone can see my screen. Good afternoon, everyone. As a lead up to the subsequent talk on food allergies in adults, it is my pleasure to actually present two cases of food-related allergies. They were actually touched upon earlier in the first talk, so I think they are also seen in the pediatric population. So the first case is a 27-year-old female who developed urticaria, periorbital and lip angioedema, shortness of breath and hoarseness of voice 15 minutes after eating homemade blueberry pancakes. These symptoms are actually compatible with an immediate hypersensitivity reaction mediated by IgE. She had eaten blueberry pancakes on several occasions in the past without problems and actually had cooked with the exact same instant pancake mix left over from the last time she had pancakes about 2 weeks ago. She has a history of moderate persistent allergic rhinitis, which is aggravated by exposure to dusty environments. Her last attack of asthma was in childhood, and she's intolerant to ibuprofen, which gives her periorbital angioedema. So in retrospect, the patient recalls actually developing allergy symptoms at least 2 other times in the last 2 years. The attacks occurred shortly after eating deep fried battered fish, and another occasion after she had Japanese okonomiyaki. The common food allergen for all 3 episodes is that of wheat, but the patient is usually able to eat wheat-based products without issues on a daily basis. So skin prick tests were performed. As you can see, there is a expected normal positive response to the positive control histamine, and there's a normal negative response to the negative control saline. The skin prick test to wheat was negative, but there are multiple positive reactions to various storage mites and also to house dust mites. The storage mites are the ones highlighted in yellow, and the house dust mites are the one highlighted in orange. The tests are supportive of a diagnosis of oral mite allergy. So oral mites actually basically refer to either houseless mites or storage mites, of which there are many species. In this picture, you can actually see a close-up of an oral mite under the microscope. Oral mites tend to infest grains such as wheat, corn, oats, and their flour products, and tend to thrive particularly well in hot and humid conditions. They have also been reported to contaminate certain foods, such as hard cheeses, cured meats, and even milk powder that has been left out at room temperature environments. On the picture in the bottom right-hand corner, you can actually see a close-up on a grain of wheat, and you can actually visualize the numerous storage mites that are crawling on its surface. So unfortunately, although cooking kills the mites, the allergen proteins, which are the mite poo, actually thermoresistant. So individuals who are allergic to them may actually react even if the food is baked or deep fried at high temperatures. So a diagnosis of oral mite allergy can actually be made when there are compatible symptoms after eating food made with mite-contaminated flour. And sensitization to the mites are usually demonstrable by skin prick testing or specific IgE to the mites. But importantly, these individuals must be able to eat foods made with uncontaminated flour, and if performed, a skin prick test to, for example, wheat, should therefore be negative. There is an association with atopic conditions such as asthma and allergic rhinitis, and a proportion of these individuals will be NSAID intolerant. Further confirmatory tests can be done, which include, for example, visually inspecting under the microscope the culprit flour for the presence of mites, or actually skin testing to a paste made with the incriminated flour that could also be performed. So how do you treat individuals with oral mite allergy? So for patients who have had serious reactions or at risk of serious reactions, they should be given a standby epinephrine auto-injector. And more importantly, actually, they should be counseled on measures to prevent exposure to these oral mites. So these will include things like avoid stockpiling of foods and checking the expiry date. In Singapore, it's very important to actually store the grains and the flour in airtight containers and keep them in the refrigerator for no longer than 8 weeks. When purchasing such products from the supermarket, it's important to check for tears and holes on the food bags prior to purchase. Inspecting the macroscopic aspect of the flour is often unhelpful because the mites are microscopic. On a producer level, actually, there are measures such as treating grain storage bags with acaricides or mite-killing insecticides. So in summary, oral mite allergy is an acute, potentially lethal allergic disorder which occurs immediately after ingesting mite-contaminated foods, and physician awareness on this clinical entity is actually required to adequately suspect, diagnose, treat, and prevent its manifestations through simple measures implemented by the patients and family members at risk. I'll then move on to my second case, who is actually a 33-year-old man who presented to the A&E for an anaphylaxis that occurred at a pub. He started to run at about 5 p.m. and within 10 minutes started to experience skin itching, which progressed rapidly to generalized urticaria, breathlessness, vomiting, and syncope. He was brought by ambulance to A&E and received intramuscular epinephrine. He recalls a similar episode 2 months ago, which occurred during a game of tennis. So looking back at the sequence of events before the reaction, the patient actually reported that he ate a sandwich about 3 hours before exercising. Likewise, he had toast 2 hours before the episode 2 months ago. These are foods that he usually eats on a regular basis without issues. He denied experiencing any symptoms of allergy immediately after having the meals, and actually felt well when he started his exercise. There was no ingestion of any other medications, and he did not recall being stung by an insect in the pub. So the patient is actually physically fit and exercises regularly without problems, usually choosing to jog or go to the gym in the pre-dawn hours before breakfast. As wheat was a common allergen to both meals, a skin prick test was performed, which showed a positive prick test to wheat at 3 mm, which is just at the cutoff. His wheat-specific IgE was class 3 positive, and component testing with omega-5 gliadin, which is actually a type of gluten within the wheat grain, was class 4 positive. This scenario illustrates a typical case of food-dependent exercise-induced anaphylaxis, where anaphylaxis only develops when a person exercises within minutes to a few hours after eating a culprit food. Very importantly, affected individuals can actually eat the food in question without symptoms if there is no exercise, and can exercise without symptoms if they have not eaten the culprit food. The most common causative allergen is wheat and other gluten-containing grains. Locally, crustaceans such as prawns are also commonly implicated. In other populations, like in the Mediterranean, nuts and fruits are also culprits, thought to be due to lipid transfer proteins within the foods. The amount of food ingested is important in some patients, and also the intensity of exercise. It is often the most vigorous types of exercise like jogging, racket sports, and dancing that are the most often implicated. However, lower levels of exertion, such as brisk walking, is capable of triggering attacks in patients with lower thresholds. Some patients will develop symptoms more readily in the presence of other cofactors, such as co-ingestion of NSAIDs, alcohol, or extreme temperatures. In Singapore, extreme heat. So other differential diagnoses of allergic-like reactions that might occur after or during exercise will include exercise-induced anaphylaxis, which is a physical allergy triggered by strenuous exercise that does not require the ingestion of food. Cholinergic urticaria is a condition where urticaria develops as a response to increase in core body temperatures, and thus would not only be limited to exercise, but also may occur after taking a hot bath or during a hot bath. There should be no systemic symptoms, and the appearance of the urticaria is distinctive, and it appears as pinhead-sized wheals, in contrast to the urticaria you might see it in anaphylaxis, where it's bigger. Likewise, exercise-induced asthma that may occur should not be accompanied by mucocutaneous manifestations. So the pathogenesis of FDEIA is still uncertain. A few studies have actually demonstrated that exercise is probably not an obligatory factor in some individuals, but instead serves to lower the threshold to developing a reaction. So a particular study actually demonstrated that 55% of their study cohort with wheat FDEIA actually reacted after taking an amount of gluten equivalent to 55 slices of toast without a need for exercise. But the same study showed that with exercise, exercise could lower the threshold to reaction and also could increase the severity of reaction. How exercise lowers this threshold is uncertain. There are several hypotheses, including increased gastric permeability, allowing increased entry of intact allergens into the circulation. So a diagnosis of FDIA is quite clinical when there's consistent signs and symptoms. And we try to demonstrate evidence of sensitization to the food if possible. So in this case, you could do a skin prick test to commercial wheat extract. If that is negative, you can actually try to use a paste of wheat, a paste made of the wheat flour mixed with saline, or even high gluten flour. And actually omega-5 gliadin is actually now widely available in referral centers. In some instances, food exercise challenges may be performed to confirm the diagnosis, but it runs the risk of triggering anaphylaxis. So affected individuals should be given a standby epinephrine autoinjector. They should be advised to avoid exercise for about 4 to 6 hours after eating the culprit food allergen. Some individuals might actually need to also avoid food for 2 hours after exercising. The simplest way actually would be to exercise in the mornings before eating anything. In some individuals who react even with the mildest of exertion, they might actually be better off avoiding the implicated food completely. So I've come to the end of my presentation. Thank you.
Thanks, Dr. Lee, for the talk. And indeed, as mentioned, physician awareness is indeed important in recognizing some of these more unusual and rare food allergies. Now it gives me great pleasure to introduce our last speaker, Dr. Tan Teck Choon. Dr. Tan is a senior consultant rheumatologist, allergist, and immunologist in Khoo Teck Puat Hospital and Tan Tock Seng Hospital. He's also deputy head of Medicine of General Medicine in Khoo Teck Puat and deputy director of our clinical immunology lab in Tan Tock Seng Hospital. He has published on drug hypersensitivity reactions as well as crustacean oral allergy syndrome. And Dr. Tan will now bring us through food allergy in adults, diagnosis and management. Dr. Tan Teck Chuan, please.
Thanks, Zijin. Good afternoon, everyone, and thank you, Zijin and Grace, for the introduction. Thanks, Wei Kang, Chairman of the Allergy Society, for inviting me to give this talk. And I have the privilege of giving the last bit of the talk, and I'm actually quite thankful and relieved because you have all received very good and informative topic discussions from the preceding speakers, and that makes my job a lot easier. And I thought I'll first share to say that I am a rheumatologist by training, and in KTPH, I am the allergist on duty, and I provide allergy consults. And I do run clinics at both KTPH as well as Tan Tock Seng Hospital. In KTPH, we do have a very simple setup. So what happens is that most of our patients do go to TTSH where it comes to further testing or for allergy diagnostics. So this point, it'll be a bit clearer when I go through a very quick case studies review in a short while. So this is my overview of what I'm going to talk about, and it's really my point of view as an adult allergist. So you've actually seen this, and I think Samantha actually went through this very well. There's some very basic definitions about what food allergy is. Food allergy, of course, is one component of adverse food reactions. And in the clinical history, it's very important for us to differentiate between what is food allergy and what is food intolerance. And within food allergy, you can actually branch it out into three subgroups based on immunopathology. And one is via, the most common thought is via IgE-mediated reactions. Then you have those which are mediated via cell-mediated reactions. And then you have the group whereby it's mixed. For example, patients with eosinophilic esophagitis, enteritis, etc. So I'm not going to go through this because I think many of our speakers have already gone through this, but suffice to say that in adults, we do tend to see more of the IgE-mediated reactions. Most of them do tend to have either mild symptoms, typically urticaria angioedema, or they may have anaphylaxis. We do occasionally see some with food-dependent exercise-induced anaphylaxis as well. It's very important that in the clinical approach to these patients that diagnostic tests should only be used when the pretest probability is high, and Samantha has touched on this as well. So in this algorithm on charts on my right-hand side of my table, basically, if you do have a patient with history consistent with food allergy, investigations are done to support your clinical diagnosis. If you have patients with very non-specific symptoms, then I do encourage you as a clinician not to order these tests. And as Samantha has also mentioned, not to order panel tests, because very often it generates unnecessary anxiety and sometimes confusion for the patient. Mixed reactions, as shown below, I'm not going to talk about this because we've already gone through quite a fair bit. The thing about mixed reactions that, for me, from my point of view, is that these patients may not typically see the adult allergist. They may actually see the specific organ specialist, meaning that atopic dermatitis with the dermatologist, eosinophilic esophagitis with the gastroenterologist. And the role of the adult allergist here is really a complementary one to aid the respective physician in managing these typically rare and can be and potentially complicated patients. Food protein induced enterocolitis syndromes, etc. These are really infancy conditions where I'm not going to talk about it. So I'll come into my first case study. This is a patient that I saw some years ago, 31-year-old engineer, and he had presented with generalized skin itch, urticaria, swollen palms, very much like the lady in the picture over there, on 5th October 2020. And he mentioned that, after initial cutaneous symptoms, he had global sensation, he had dyspnea, and there was noisy breathing. He had abdominal pain, the urge to defecate, and there was actually passage of loose stools. And he reported a history that he had one episode of passage of loose stools sometime earlier at 7:30. And when we looked at the food history, his last meal was dinner, and that was fried Hokkien prawn noodles. He didn't take any of the prawns, and a fresh pack of chicken and biscuits. It was around 7 o'clock. He was managed at the KTPH ED. He had arrived at about 1 in the early morning. At that point in time, he had stable vital signs. Interestingly enough, he had no rash by then. He was given antihistamine oral steroid. The ENTs got to him, established that there was no airway compromise, and he was discharged well after a period of observation. So when he came to see me in clinic, some time had passed, and so I interviewed him and queried for further history. Really, in terms of apart from the diet dinner that he had, there were no other clear cofactors or potential triggers that could have precipitated his reactions. He also had no significant past medical history and no atopic history of note. What's interesting, of course, is that there was that history in his food and diet history that he had previous episodes, quite similar. Skin itch over both hands after consumption of steamed crab, and also an episode of generalized urticaria, dyspnea, and vomiting after food, except that he can't really remember what food he had taken then. Since the episode in October 2020, he had avoided all crustacean seafood except fish that he realized that he could tolerate without quite well. Other food groups, no issues. So at that visit, it was quite clear to me that, quite likely this patient had food-induced anaphylaxis, and prawn was the likely allergenic food in this case, and he was advised avoidance. We went through avoidance history, management of accidental ingestion of food, and he was equipped with an allergy action plan and was taught self-management with an EpiPen. So this on the right is an example of an anaphylaxis action plan. This was actually it's actually available on the ACIS website. He, on the first consult, had blood extracted, and we sent him for allergen-specific IgE to shrimp and crab. And again, he both returned as class 1. And class 1 is really, basically class 1 is regarded as an equivocal test, and typically class 2 and above are considered as positive tests. So they didn't change our diagnosis. Again, like I emphasized, the diagnosis was clinical, but he was actually quite keen to explore this further basically in terms of whether or not he could tolerate other food groups within the crustacean. So he went on to see me at the Tan Hock Seng clinic 2 months later, and he had skin prick test done. And in this case, you can see from the chart on the right-hand side that actually he tested negative to the commercially available food extracts for commercial seafood. So, which was a little puzzling. He then went on in November that same year. He had a prick-to-prick test and with Chugray prawn, and the test returned positive here. He developed a positive wheel and flare reaction to steamed gray prawn, and therefore we did not pursue further with oral food challenge. And in October this year, when he came back for his last review, he continues to practice avoidance of all crustacean seafood. He carries an EpiPen, and he has had to take the occasional oral antihistamine after food, and it could be that he suspects that it could have been some residual allergens in the broth that he consumes. So the main point here is that clinical history is really key. Negative tests with a compelling history should be managed as per clinical diagnosis. And as my colleagues have shared, oral food challenge may be useful in patients with positive tests with ambiguous history. In Tan Hock Seng some years ago, and Professor Bernard Tong and colleagues had looked at this, you can see from a retrospective review of about 74 consecutive patients in the allergy clinic at TTSH, crustacean, seafood allergy, mollusks, crustaceans and mollusks makes up a good 50% of the commonly implicated food in the adult. And in this group alone, 66% of them had symptoms of anaphylaxis. If you look at this very busy chart on the left-hand side, what I'm trying to say here is that shellfish allergy or crustacean seafood allergies actually ranks pretty high in most Asia-Pacific regions, and is probably related to our diet. And if you look at countries like Vietnam and Hong Kong, where the studies looked at patients not just in the pediatric age group, but in the adult age group, you would see that crustacean seafood ranks pretty highly at first. And this is in contrast with the Western population, if you look at the chart on the right, whereby prevalence of crustacean seafood allergy can vary from 1 to 2%. But in Asia-Pacific countries, for example, like in the Philippines and in Singapore, it can go up to as high as 5%. What we've also learned is that the main allergen to crustacean seafood allergy is actually to tropomyosin. And but what we know also is that there has been groups in China who have looked at it and have established that actually amongst their population, most of the patients with crustacean seafood allergy have positive IgE or evidence of sensitization to troponin C and fatty acid binding protein, different forms of muscle protein within the shellfish. The differences in the allergy could also be because of the way that we prepare our food. So in Western countries, it could just be deshelled prawn or sometimes raw prawn, whereas in most Asian countries, the prawn is actually cooked whole in broth. And as some of us will know, there is also quite a fair bit of some patients or some people actually do like to ingest and take in the contents of the stomach, the ovaries, etc. So that actually causes some differences in terms of the culprit allergen in patients with crustacean seafood allergy. Again, this has been gone through before, but when we talk about shellfish, actually we are looking at two groups here, mollusks and arthropods, and crustaceans make up one group of the arthropod. And interestingly enough, house dust mites, spiders, cockroaches, wasps, and bees are also considered as a same family group within the arthropods. And what it means is that there is significant cross-reactivity, and we also do know that patients with a background history of allergic rhinitis sometimes do demonstrate cross-sensitization to crustacean allergens, and that sometimes can cause some confusion when allergen-specific tests are done in uncertain clinical scenarios. This very busy chart here actually shows the cross-reactivity amongst crustaceans, insects, mites, and mollusks. And in our clinical practice, we do notice that patients with a background history of allergic rhinitis do demonstrate sensitization to crustacean allergens pretty commonly. So I'm done with my first case discussion, and this is coming down to my second case. So the second case is a little bit similar to Samuel's. So I'll try to go through this a little quickly. It's a 52-year-old Chinese male. He's a financial planner. He first developed allergy on February 2018. He had acute onset of generalized itch and rash at 9 in the morning whilst on the MRT train. He was actually headed to work from his home in Yishun. He got off at the Ang Mo Kio MRT station because he was really unwell, had to see a GP, and actually fainted as he was about to reach the GP clinic. He was picked up by passerbys. SCDF got to him. He was hypotensive. He was given fluid resuscitation, and at the ED he was still hypotensive. Given at that point in time, interestingly enough, again, no rash, angioedema, or respiratory compromise. But the ED had decided to give him adrenaline and fluid resuscitation, and he had good response. He was discharged well the following day after observation overnight at the EDTU, and it was actually equipped with EpiPen and referred to me in my clinic. We went through the dietary history. He had breakfast that day at about 8:15 in the morning. He had a wholemeal bun with nuts with blackberry jam with water for breakfast. And he had mentioned that he had purchased these from a recent supermarket run to JB. So he wasn't exactly very sure about the contents of the food that he had eaten. But he shared with me that his usual routine in the morning would be breakfast at around 8. He would then walk for about 10 minutes to get to the Yishun MRT station. And that, we went through again, there were no suggestions of intercurrent viral illness. He said he wasn't running, he wasn't rushing, and really, really quite well. No past significant atopic history of note here, no history of spontaneous urticaria. Having said that, he was actually labeled to have an allergy to famotidine and domperidone in 2012, and the reaction was generalized urticaria, although I wasn't able to get much further history from there. When we explored his food history, he did have similar episodes before. He had acute generalized itch and rash and urticaria whilst on the MRT in the morning. He had gotten off to see a GP because, again, he was itchy and feeling unwell, but at that episode, he had no syncope. He also had a prior episode of generalized urticaria, as I mentioned earlier on, that was attributed to drugs. No history of food allergy to bread, pasta, noodles, peanuts, or tree nuts, and no significant allergy intolerance to other food groups, including grains. At that point in time, the provisional diagnosis was food-induced anaphylaxis, and was wondering whether, as Samuel shared his first case, whether this could be a mite allergy or perhaps tree nut allergy. And we had planned for a diagnostic skin prick test for this gentleman, but he was unfortunately not too keen to make that trip to the Tan Tock Seng Hospital, and he had decided that, he would want to just watch and wait for that at that time. So he kept his EpiPen and the anaphylaxis action plan in the meantime, and we decided on regular surveillance and monitoring. In May, he again had the same problem. He had generalized itch with urticaria whilst walking in the morning in the MRT train to work. He had gardenia wholemeal bread. He had bakwa, which is basically our Asian beef jerky, and milk. he used his EpiPen, got to a GP, got himself treated, and he was well. The following day, he tried again with another brand of wholemeal bread. He ate it, and he was fine. So that's what he shared with me. And so at that point in time, we thought about it and thought, okay, it's most likely, in this case, are we really dealing with, could it be that we are dealing with food-dependent exercise-induced anaphylaxis? And we talked about eliminating wheat from his diet, in which case he was actually not very receptive at this point in time. And bear in mind that he actually had no exercise, he was just walking to work. He continued to decline diagnostic skin prick tests. So that visit we did wheat and omega-5 gliadin IgE after an 8-week period wait from his event. Those tests came returned as class 0 negative to wheat. He had class 2 positive to omega-5 gliadin, and his baseline serum tryptase levels were not elevated. The diagnosis I made at that point in time was FDEIA, and most likely it was to omega-5 gliadin, a wheat protein allergen. And the avoidance advice to him was really, not to have, maybe go to work on an empty stomach and have your breakfast when you get to work. So what has happened since then? In 2018 and 2019, he remained allergy-free, and he continued to take wheat-based food. He still continued to take bread for breakfast, but he said that he was very careful not to rush when he was headed out for the MRT in the morning. 2019 and 2020, as you know, it was COVID years. He was lost to follow-up. He came back much later on in 2020 for 4 episodes of generalized urticaria after taking bread for breakfast. Symptoms would occur again as he was walking en route to work. He wouldn't rush, and I began to think that perhaps it could have been that heat was an exacerbating cofactor in this case. So strongly advise him not to take any bread for breakfast following those 4 episodes. 2021 to 22, he followed my advice. He stopped taking bread altogether. He was well. But interestingly enough, he reported an episode of urticaria after taking mee pok noodles. But later on, no recurrence on similar food exposures thereafter. So in this gentleman, I thought that, what was the key take-home point here is that, you do need a periodic re-evaluation in these patients. And it's actually important when you have clinical uncertainty, or if you're practicing in a setup like mine, whereby you may have limited testing capabilities, or if the patient was not keen for further test evaluations. And following up the patient, maintaining a good food activity diary is actually very important in the management of such patients. At the EIA, Samuel has talked about it, but I thought I'd bring up this very recent review paper just published in JACI September 2022, whereby they actually looked at 722 reported cases of FDEIA. And well, when they say A here was actually not anaphylaxis, but like anaphylaxis and allergy. But it was interesting to note that actually walking was the activity that triggered in up to 10% of these patients. And the common allergen here, as Samuel has mentioned, 90% was actually to wheat. 37% of them actually reported a history of urticaria, and 1 in 6 cases only had angioedema or urticaria instead of having anaphylaxis. So very similar to what the patient demonstrates over the years of follow-up. I'm not going to go through this, but it does seem to suggest that both allergen-specific IgE testing, skin prick testing are pretty sensitive tests in these patients. And even when you do oral food challenge, when you do exercise challenge, you get a positive rate of about 45 to 65%. So that's not all that great either. In a retrospective review, this is in Australia, when they surveyed 43 patients who were diagnosed with FDEIA, they found that actually what was most important was the separation of food from exercise, rather than complete separation or complete avoidance of wheat. So if you were stringent, you avoided wheat after exercise, you will find that the reaction rate after diagnosis was much lower as compared to those that did not adopt stringent measures. Okay, sorry, this is the chart, liberal and stringent. So liberal, if you're liberal with your diet, you don't avoid food, then exercise, then you have a higher reaction rate as compared to being stringent. So I'm almost at the end, and I finished with my case studies, and I just want to talk about some of the more recent lab investigation modalities that are open to us as allergists. And the first one, of course, we have spoken about it many times here, is component resolved diagnostics. Now, what does CRD mean? CRD is basically refers to the use of recombinant protein technology to create assays to detect specific IgE to allergen molecules. And The very busy chart on the right actually shows the different types of CRD in soybean, peanut, and in wheat. And I show wheat here because, like in our second patient here, the CRD allergen here was actually omega-5 gliadin. And that's been quite well demonstrated to be the main culprit allergen in patients with wheat anaphylaxis. There is thinking that in patients with a positive CRD, you may potentially be able to skip an oral food challenge. Reducing the risk, as Sammy has mentioned, there's often that risk that you have a repeat reaction or severe reaction when you do exercise challenge. And as I've also shared that, exercise challenge sometimes may not be specific. Component resolved diagnostics can also help differentiate between patients with sensitization as a result of allergic rhinitis as compared to true prawn allergy patients. And this particular paper from China looked at that. They actually looked at a group of patients with prawn allergy, allergic rhinitis, and control patients. They then used CRD to brown shrimp, PAN A1. And what they showed was that in those with true shrimp allergy, they would have high levels of PAN A1, whereas controls mild allergy patients will not have that. What is the issue with CRD? You can see from this chart here that I've compiled here from a recent paper that CRD has actually been very well documented with sensitivity, specificity, PPV, and MPVs for the pediatric population. And you can see here that most of the links here are for patients with age less than 18 and with the attached links. So what that means is that you don't really have that much information when it comes to the adult patient for component resolved diagnostics. And that is a challenge. So what's on the horizon? So this is from a recent paper about lab diagnostics for allergen-specific IgE. There is a thinking that perhaps for patients with food protein, most of the food allergies are to protein. There are a couple of them which is actually to polysaccharides. But there's a thinking that perhaps we can be using multiplex ELISA assays to look at more allergenic epitopes. For example, in peanut protein, we might be able to look at more allergenic epitopes. And if we were able to run these assays through a multiplex assay, you'll be able to have many different IgEs to peanut-specific epitopes. And the composite IgE levels of that with proper validation would be able to give you a more accurate diagnosis. I would say that at this point in time, this remains very aspirational locally, primarily because we don't have big cohorts, and any form of results from these studies would require extensive validation. My colleagues from pediatrics have also spoken about basophil activation tests using flow cytometric technology. And there's actually another test called mast cell activation test, and the technologies here are very similar. You are using sera from the patient, you match it to IgE, you match it to the food extracts, and you look for basophil as well as mast cell activation via flow cytometric technology. But again, here you do require proper validation studies. GALEN is the European Network for Food Allergy, and this was actually a recent guidelines just published in 2022. When we look at oral immunotherapy and the use of biologicals, oral immunotherapy, as you have heard, is something very exciting and new in the pediatric population, but actually in adults, there's actually very limited evidence. Thus, in the most recent European guidelines, there's been no mention or recommendations on oral immunotherapy for adults. Biological therapies like omalizumab can sometimes be used to ameliorate the symptoms of OIT. Again, there's not much evidence for that for use in the adult with food allergy. So there's really quite differing data, and the chart on the left-hand side here looks at a large allergy center in Israel. What they have shown is that when they looked at OIT for food allergy, there did not seem to be a significant difference, with desensitization rates between adult and children. In milk OIT, they did find that adults tend to have a higher failure rate as compared to kids. However, there were also other studies, and this published in NEJM 2018, where they look at peanut OIT in adults, very, very small number. And in that study itself, it did not meet statistical significance where it came to desensitization rates as compared with placebo. This is my last slide. And really my thoughts about food allergy in the adult. The scope of understanding of food allergy, in particular in the adult, is really expanding. And the allergy phenotypes have geographic and population differences. More can be done in validation of test techniques, especially in our adult population. And at the moment, there is a really limited therapeutic options for the adult. The good news, of course, here is that most adults thrive simply with avoidance of the allergenic food. And I think one other factor here is that most adults with food allergy, especially the milder ones, do not view this as a problem, and often they do not seek clinical consult. So very often the ones that tend to see us in clinic do end up to be those with anaphylaxis rather than just mild allergies, mild urticaria, angioedema. So consequently, what then happens is the study of adult food allergy and resources in the management can sometimes be limited. With that, I end my talk. Thank you.
Thanks very much, Dr. Tan, for such an informative and comprehensive talk. So there have been, we've come to the end of the webinar, and now it's time for Q&A. There have been some questions that have been answered live on the chat already. And so we don't have any outstanding. So since we do have a bit of time, I thought I'd just like to throw a few questions to our panelists. I think one, we should link Dr. Tan Teck Choo's talk with Dr. Lydia's talk. Perhaps I'd like to ask on whether there's any immunotherapy and what the status is for prawn OIT.
Thanks, Sachin. I think prawn OIT is really something that is very relevant to this region. Currently, no one has done it. So there are a few case reports, I think, of patients. I think there were 3 patients who were desensitized to prawn as part of a multi-food OIT program in a Stanford study. But this was with the use of omalizumab. So they used omalizumab as an adjunct to be able to do multi-food OIT. And this was just a very small percentage of a much larger cohort that they were investigating this in. So my research is actually looking at prawn OIT. And I think it would be very relevant for our population. One of the main difficulties to prawn compared to other foods is that prawn can be a species-specific allergy. And it's also, so you would need to desensitize each person. You may need to do more than one prawn species. So you might need a multi-species food powder, for example. So clinically, you have patients who can tolerate tiger prawn, but they will react to glass prawn, for example. And of course, unlike other foods like egg, where you can get egg powder or peanut powder, it's actually quite hard to find a form of prawn protein that's amenable to the OIT regimen. It has to be, you have to be able to titrate it. It has to be shelf-stable. It has to be microbiologically stable. So these are some of the challenges, but we have some pilot studies, and so far the data is quite promising, and hopefully we'll have more to share if the research moves on.
Thanks very much, Lydia. Yeah, I think prawn oral immunotherapy is something that a lot of patients in our adult allergy clinics ask a lot, since prawn allergy is actually more prevalent in adults, and being Singaporeans, we're all foodies and we do love what we eat. And so I think that brings me to another interesting question that perhaps I'd like to ask Dr. Samuel Lee. We also have a lot of patients in the allergy clinic asking us about possibilities of food dye or food coloring allergy. Dr. Lee, do you have any take on this question? Thank you.
Right. So thanks for the question. Food dye allergy is rare, but there have been, and I have seen patients who actually report having reactions like urticaria shortly after they eat red colored foods. And actually it's been recognized that they might be actually reacting to carmine, or which is a food coloring made of cochineal, which is actually an insect that grows on cacti, and they actually harvest these insects to make that red colored powder. So they might report the reactions after eating things like commonly strawberry flavored yogurt, red colored cakes and desserts, red colored macarons, sometimes even in red colored meat. So that is something to think about. It can be tested either by skin prick testing, but more readily testable by using actually carmine specific IgE, which we can perform.
Okay, thank you very much, Dr. Samuel. Okay, I think that is all the questions. Oh, we have one more. Some adults get a delayed hypersensitivity reaction to alcohol products. The question is whether this is a food allergy. Could I invite any of the speakers to take this question on alcohol and allergic reactions? Again, I think something quite common that patients in our adult allergy clinic do ask us.
I can take this question. I think to my experience, quite a lot of people report this, and the question is really what reactions they have. It's very common to have what they call the Asian flush, you know, where it's really a matter of deficiency of alcohol dehydrogenase enzyme, where you get this sort of flushing, lightheadedness, a little bit of wheals as well. And these patients, they tend to be quite consistent. So they report it across all groups of alcohol, whether it's wheat-based like beer, rice-based sake, wine, you know, all forms of alcohol, and typically dose-related. But in terms of specific allergies, we have had 1 or 2 patients who had adult onset grape allergy. So this patient who had anaphylaxis after taking wine. So that has been reported. Some patients have also been reported to have allergy to even adult onset wheat allergy as well. So I think for the majority of these patients, they may not be allergic. They may either really just have the enzyme deficiency. They may be reacting to histamine or to sulfites in wine, which may be present depending on the mode of production of the wine. And a very few of them may have a new onset through IgE-mediated allergy.
Okay, thank you, Lydia, for answering that question. In fact, yeah, a lot of the adult side in our clinic, we have patients have been referred for suspected alcohol allergy, which is usually not alcohol allergy. Yeah. Okay, we have past 4, and we definitely had a great 4 great talks and fruitful discussions. And on behalf of the ACIS and the section of Allergy and Clinical Immunology, I would like to thank all participants who spend the Saturday afternoon with us, all panelists and all speakers. May everyone have enjoyed the rest of the weekend. Thank you, everyone.
Thank you. Bye.
Thank you.